there are many different types of coverage. Now, thankfully, a very clever man, Tanahashi, in 1978, developed a model of coverage. And he breaks coverage down into a series of coverage types. And at the bottom there is availability coverage. Is the service available? Above that is accessibility coverage. The service may be available, but is it accessible? Yeah? Can we get Muslims to come to a program run by Catholics? Can we get Catholics to come to a program run by Muslims? Yeah? Right? Is it an acceptable? Is it an acceptable program? So I would guess that in our CMAM programs, if we were forcing the mothers to have urodynamic assessments, it wouldn't be a terribly accessible program. Contact coverage, this is what we usually mean by coverage. Yeah? The number of people we contact, the number of people we bring into the program. And lastly, effectiveness coverage, we can think of that as our cure rate. So our impact, the goal of our service achievement, is a complex product of all of these types of coverage. And ignoring one level of coverage or many levels of coverage means that we don't understand why our coverage is as it is. And I'll come back to some of these levels as we go through. Let's have a look at the next slide. So first off, I want to talk about the sorts of coverage we can get from routine data. No, we're not really assessing coverage. We're not spending money assessing coverage. We're just seeing if we can stick a damp finger in the wind and get an answer. And one of the ones that I rather like, that has been used by UNICEF, is geographical coverage. They call it geographical coverage. This is in effect availability coverage in the Tanahashi model. Now, we can say here, the problem is there's no clear definition of geographical coverage. We can say here, geographical coverage is the number of primary healthcare facilities delivering CMAM services divided by all the facilities that we could deliver CMAM services at. Now, that's quite nice. Yeah? The other one is districts with greater than or equal to one primary healthcare centre divided by the total number of districts. Both of these have been used and both of these have been reported. Now, the problem is these are very, very, very different indicators and give you very, very different answers. So let's imagine we've got 600 health facilities in our country, 15 districts. Yeah? Now, we could say we're delivering in 30 clinics. Yeah? So 30 upon 600, that's 5%. Our coverage, our availability coverage is 5%. That's the best we can do, 5%. However, if we say we've got one in each of those 15 districts, then our coverage is 100%. Now, they're very different answers. They're very different answers, and which one is correct? And the problem is with coverage is that both of these are correct. But we have to be clear what they tell us and what they don't tell us, and when we quote them, we have to be clear which one we're quoting. Next slide, please. Now, this version, this is the facilities that we deliver at divided by the total number of facilities that we could deliver at, corresponds to availability coverage. So if we've got some form of rational deployment of our health centres, our resources, our bricks and mortar resources, then this would give us availability coverage. We can say this is the maximum coverage we can possibly achieve. That's one way you can do it. This version, which is the greater than one clinic per district, that doesn't seem to correspond to anything in the Tanahashi model. This is way out there compared to the way coverage is perceived in any other health delivery system. But it might still be useful. Somebody's thought it was useful. Yeah? Several country offices from UNICEF have thought this was useful. And I don't believe they're gaming the indicator to make themselves look good, though that could be a possibility. Yeah? They obviously thought this would be useful. So I think that we can explore how could this be useful. And I think it's useful because health delivery systems are almost always delivered within a hierarchy. Next slide, please. So the hierarchy is typically, this is the UK, nation, region, district, facility. In Sierra Leone, this is nation, district, chiefdom, facility. In Sudan, this is federal state, local state, locality, facility, with management at all levels. And this pattern repeats itself throughout the world. I think if you were to look at Afghanistan, you might find something different. If you were to look at Somalia, you might find something different. But unless we're dealing with non-states, failed states, then this is the sort of hierarchy that we're working within. Next slide, please. Oh, and it might be useful to measure coverage at each level of the hierarchy. Next slide, please. So here's a complicated figure, but we're showing the geographical coverage at different levels. So at the nation, that's the number of regions offering CMAM services divided by the number of regions. At the regional level, that's the number of districts offering CMAM services at the district level. And at the district level, that's our availability coverage. That's number of facilities in the district offering CMAM services divided by the total number of facilities that could be offering CMAM services in that area. Now, a table is not a great way of presenting this sort of data, but it does show the hierarchy. Next slide, please. Now, 3 levels, 3 indicators. Can we have a headline? Is it useful to have a headline? Well, as I've said before, the facilities level coverage is the one that most closely approximates availability coverage in the Tanahashi model. So that really should be, if we're going to quote one, that would be the one that we should quote. But if we use 3, then the other 2 indicators are not providing us with nonsense data, they're providing us with diagnostic data. And so I'd like to imagine program A and program B. Program A is what's presented in the table. And here we see that the geographical coverage of the region is 2/3. 2/3 of regions are offering CMAM services. We don't know what sort of CMAM services there are. Might just be one clinic in one district in one region. But at least something is going on in that region. At district level, so within the regions, 56% of districts have got some sort of CMAM service being delivered. And then down in the district level, when we're looking at facilities coverage, we've got 42% of districts offering, of facilities offering CMAM services. So our maximum coverage we can possibly achieve is about 42%. Now, the second program is a very different program. We see here we've got 100% of the regions have got CMAM services, 100% of the districts have got CMAM services, but when we look at the facilities coverage, the availability coverage, is down at 8%. And we can see here we've got a program, the first program is rolling out rationally on a region-by-region basis, on a district-by-district basis, and a facility-by-facility basis. The second program is going for gold, is trying to roll out big time nationally. So we've got all the regions signed up, we've got all the districts signed up, but it's doing nothing in terms of availability. So we can see 2 different types of programs. So having the 3 levels of statistic, we can diagnose programs here. And I think it helps. I think as well this helps to avoid the confusion that we have between 100% regional coverage and 5% facilities level coverage. It's clear if we keep the 3 indicators, which statistic belongs to which indicator. If we just use the bland term geographic coverage, we don't know which statistic belongs to which indicator. Next slide, please. So, of course, if you've got tables are nonsense, really. Yeah? You can map these, and here's a made-up data. But the maps are much more easily interpretable than tables, yeah? And the spatial dimension is much clearer. Because when we're talking about districts and we're talking about regions, we are talking about spatial entities. So having geographic coverage, we should map it. We should know where our service is being delivered and where our services aren't being delivered. So probably best here to map the facility level coverage by district, which is the lowest level of health delivery in our hierarchy. Next slide, please. Now, all sorts of problems. And I don't want to bore you with sets of problems. This is just some of the sets of problems. Yeah? Some of the sets of problems. So we can have improper numerators. Yeah? Right? So we need a strict definition of what it means to deliver CMAM services. So in Sierra Leone, for example, not now, but in the recent past, in Sierra Leone, for example, delivering CMAM services meant that when somebody came to a clinic, they had a Myatt strap put on their arm. If they had a Myatt below 115 millimetres, they were referred to a clinic 20 kilometres away. Now, there was a lot of loss there. At least there was screening going on. Yeah? But I don't think that counts as offering CMAM services. That's offering screening, which is a different thing from delivering CMAM services, I think. It's just one part of CMAM services. We can have improper denominators. Yeah? So this is something I've seen in Sierra Leone, in Niger, in Sudan, in Ethiopia, where we say, oh, well, the clinics that we're offering CMAM services in are the only clinics that we are ever going to offer CMAM services, because the other ones, well, we don't care about them, they're not real proper clinics. Yeah? And so they cut away all the clinics that they don't want to deliver services in, and they end up with 100% coverage. Yeah? Now the problem with that is, the problem with that is that I go to the clinic with little Tariq. Little Tariq's ill, he's thin, he's had a bout of diarrhea and fever, he's not recovered. I think, oh, I better take this child to the clinic. Yeah? I don't need to know. If I have 100% facilities coverage, I don't need to know where the CMAM clinics are. The child go to the clinic, he's picked up hopefully by the screening services, and he's in the CMAM service. Yeah? If I've only got partial facilities coverage, I take my child to the nearest clinic, the clinic that's most convenient for me. If they're not offering CMAM services, poor little Tariq's got a what, one in three chance of dying. Yeah? Incomplete spatial coverage. This is very important as well. So if we've actually got no clinics at all, or just one clinic serving 100 million people, then just having one clinic gives you 100% coverage. What we need to do is we need to maybe contract that to a reasonable, what would you call it, a reasonable catchment area. Yeah? And we can misspecify catchment areas. So in Sierra Leone, for example, this was a wonderful piece of gaming, is that for every other health delivery, for every other health service we were delivering, the catchment area was the catchment area of the clinic. And it was a catchment area of the clinic that was roughly halfway between clinics. Yeah? So you can have a polygon of coverage around each clinic. Whereas what they did in Sierra Leone is they said, oh, we'll stick one in the main town and we'll say that that main town's clinic has got a catchment area that covers the entire district. So there's ways to game this, so we have to be very careful about the gaming. But if used honestly, it measures something quite useful. Now, moving on from measuring something quite useful, next slide, to measuring something quite useless. Now, one way of estimating contact coverage is to say, well, it's the cases treated divided by the need over a period. Now, that means we have to know the cases treated. Now, maybe we do have a good health information system that gives us the cases treated, but we also need to know need. And how do we estimate need? Well, as Andre spoke about yesterday, that we only have prevalence surveys. So we have to turn prevalence into incidence. An incidence might be 2, 3, 4, up to 8 times prevalence, but you don't know what it is. So we have need is our population, which in emergency situations is unpredictable. We've got displacement. We have our prevalence. And when we're talking about SAM, our estimates for SAM are quite imprecise, and K is a fudge figure. It's a fudge figure to turn prevalence into incidence, and we don't really know what that is. So there's tremendous amount of imprecision, inaccuracy in this type of indicator. And you end up with useless coverage statistics such as, oh, I've spent 90% of my budget, so I must have 90% coverage. That's this type of statistic here. Next slide, please. The only real way to get a contact coverage is to actually try and measure it directly. And so we're talking here at national level. We have plenty of methods to measure coverage at the district programme level. Squeak would be a classic way, a good way of measuring coverage at the district level. At the national level, we have the simple spatial survey method. This is an evolution of the original centric systematic area sampling that we used in the CTC research programme. The one that showed us that TFCs didn't have any spatial reach, but CTC had great spatial reach. It's cheaper than the CSAS survey. CSAS was a research tool. We didn't really think about optimising it for use day to day. It covers about 10 times the area for about 3 times the cost. It gives us better precision and better spatial detail than CSAS. Now, Ernest, I believe, is going to be talking more about S3M, so we don't have to go into that. Yeah? CMAM coverage and multiple indicators. So we've got IYCF, we've got small sample IYCF indicators, WASH indicators, EPI, IYCF. We've got a whole panoply of indicators that we can stick into an S3M. But we can do coverage, and we have done coverage. The other approach that we've used is a combination of SLEEK and Squeak. Now, SLEEK is a very fast small sample classification method. It uses a 3-tier LQS classifier, typical sample sizes between 30 and 40, and we classify. And we can do this quickly with a small team over wide areas. And if we do that, we'll find districts with poor contact coverage and districts with reasonable contact coverage, hopefully. Now, what we can do then is we can go and do Squeak surveys, Squeak assessments, in the poorly performing programs and in the well-performing programs, and we can compare and contrast. Now, the Squeaks are quite quick because we have barriers data from the SLEEK surveys. So we have some prior information to inform our Squeak surveys, and so we can compare and contrast. In Sierra Leone, where we've done this, we did a whole country in 44 days with 15 staff. We were punting out district-level results every 4 days, every 4 to 5 days. I think it's right, Ernest, yes? Yeah? We have classifications at the district level, and at the national level, we have estimates. But of course, if the classifications are all over the place, we've got patchiness, then a national estimate is pretty meaningless. Next slide. Here's an example of the simple spatial survey method. This is the mostly habited area of Niger, and we can see that the red areas are the poor coverage, the yellow areas are the not so bad coverage, and the green areas, that would be where we'd be above 80%, but I think there's a pale green area somewhere there. Yeah? In the northwest, yeah? Yeah. Next slide. Here's a Squeak SLEEK classification map. This is Sierra Leone, and we can see the Sierra Leone program was failing seriously. The coverage standards here are not sphere. The red are below 20%. The green, they're not there, are above 50%. And the yellows are somewhere between 20 and 50%. But we can see that there's something going on in Bo, Kenema, and Pujahun that's slightly different from going on in the rest of the country. Yeah? But when we go and look at the Squeaks, and so what we did is we chose the worst performing of the districts. Next slide, please. We've got the classic Squeak diagnostic, the concept map, what barriers, what bottlenecks are there in the program, how these bottlenecks are reinforcing each other, what boosters there are in the program, how these boosters are reinforcing each other or attempt to ameliorate the barriers and bottlenecks that we've identified. So it gives us great diagnostic, it gives us great information for program reform. Now, that said, the simple barriers data that we got from the old CSAS, was good enough for us to be achieving 80% coverage, 70, 80% coverage. I remember Emily's program, we had, what, 70% coverage? Yeah, with just that CSAS data was enough. Yeah, but this should get us well on the way to very, very high coverage. Next slide, please. So in summary, I think we've got 3 methods I've discussed: routine data, S3M data, SLEEK and Squeak. Now, in routine data, we can get availability coverage. We might be able to get accessibility coverage if we can bother to get our compasses out and draw little maybe 5, 10 kilometre circles around our health centres and make some form of adjustment. We can't get acceptability coverage because that requires getting into people's minds. Contact coverage, that's going to be imprecise and inaccurate, and effectiveness coverage depends upon contact coverage, so that too will be imprecise and inaccurate. The cost is low. I think because the cost is low, it should always be done. Limited barriers data, we know how to do it. We can do it. It's not hard. S3M, we can get everything from S3M. Its cost is moderate. And when I say moderate, it's moderate compared to doing smart surveys everywhere, or doing squeak surveys everywhere, or doing CSAS surveys everywhere, but it's not cheap. Gives us barriers data as a CSAS, which we know have been useful in improving coverage in programs. Skills required for this. Valid has the skills required for this. Some UNICEF country offices, for example, say Ethiopia, Sudan have skills for this. Some of the MOHs, particularly in Sudan, and some departments like ENRI in Ethiopia have skills for this. I think what's required for us to use S3M is some mechanism of skills transfer. Now, I know a skills transfer mechanism, yeah, and that's been CMN. So it would strike me that something like CMN would be required for a skills transfer, and so we'd need a skills transfer from these UNICEF departments and from Valid to CMN, who then acts as a skills transfer conduit to other UNICEFs, ministries of health, NGOs. Yeah? That's a reasonably large project. But CMN is a reasonably large project, and I think they've shown that they can act as a skills conduit. The tools for S3M are, you have to be honest, they're reasonably mature. They're not fully mature, they're reasonably mature. It's at a stage now where when we take this thing out for a walk, we're very confident that we're going to get good results, but sometimes we learn new things and we modify the method to give us more. It's a very, very good method. It's a very strong, high information yield method. We've moved in the past year from having a spatial resolution of maybe 15 kilometres to having a spatial resolution that's down to we have an estimate as to what coverage is just here. Yeah? Without very complex spatial statistics. The spatial statistics are pretty complex, but they're not as complex as conditional Kriging or these sorts of things where you have to go to oil companies to get these, and the person will be charging you $5,000 a day for the services. Yeah? Sleek and Squeak, its costs are low to moderate. Low to moderate. Yeah? Periodic surveys are feasible because the cost is low to moderate. Yeah? Barriers data from Sleek is the same as the barriers data from CSAS. We know that's useful. We get barriers and boosters data, diagnostic data, the interrelationships between barriers and boosters from the Squeak. The skills required are currently with CMN and at CMN partners. So this is a low initial start overhead. It's a low training overhead, I think. That method is fully developed. Yeah? Last slide. Thank you very much.